All right, I think we can go ahead and get started. My name is Kaylee Sadoff. I am the program lead for a joint initiative between the American Heart Association and the Centers for Disease Control and Prevention to further heart valve disease education and awareness. I'm going to go through a few housekeeping slides before we get started. All attendees are muted upon entering the session today, and you may use the Q&A for questions as we go along, and we'll address all of those questions at the end of the presentation. This is a continuing education activity. We are doing a three-part series, and so this is the first, and we can earn up to 0.75 CE credits. I'm going to tell you a little bit about the initiative and then introduce our speaker for today. In 2024, the American Heart Association received a grant from the Centers for Disease Control and Prevention for projects that will help increase awareness and education of heart valve disease. This grant will allow the association to expand in three areas of heart valve disease education. We have a national communications campaign, heart valve disease education and awareness among healthcare professionals, as well as a women's heart valve disease education and awareness capacity building out in the community. The precursor to this grant was the Carroll Act, which is the Cardiovascular Advances in Research and Opportunities Legacy, which was signed into law in 2022. U.S. Congressman Andy Barr introduced this into the House to honor the legacy of his wife, Carol Lovell Barr, who passed away tragically from sudden cardiac death caused by valve disease. The American Heart Association has invested in heart valve disease spanning across different initiatives and has begun to look even further upstream of procedure. And this grant in particular will allow us to go to the initial opportunity for identification in the primary care setting. Through this work, we've been able to prioritize collaborating with external partners to help disseminate resources developed through the initiative, build scalable work through 15 valve centers across the country who are working with their referring providers, initiate landscaping to determine where the gaps in patient care pathways remain, and disseminate new resources to amplify our efforts in heart valve patient ecosystem. So, as a part of a healthcare professional education, our cohort of valve centers has developed a comprehensive webinar series beginning today with screening and detection in the heart valve disease patient journey. If you've not registered for the next two, we have plenty of opportunity to do so. Those will be in July. And today I would like to introduce Dr. Ty Gluckman. Dr. Gluckman is the medical director of the Center for Cardiovascular Analytics Research and Data Science at Providence Heart Institute in Portland, Oregon, an adjunct faculty member of the Cicerone Center for Prevention of Heart Disease at the Johns Hopkins Hospital in Baltimore, Maryland. His principal clinical interests include identifying, coordinating, and implementing cardiovascular care improvement strategies. He has authored or co-authored over 100 scientific articles, reviews, and book chapters. His work has been published in several high-impact journals, including the Journal of the American College of Cardiology, Circulation for Cardiovascular Quality and Outcomes, Journal of the American Medical Association, Journal of the American Medical Association Cardiology, Journal of the American Heart Association, and New England Journal of Medicine Catalyst. He previously served as associate editor of the Journal of the American College of Cardiology, associate editor for the Guidelines and Clinical Documents for ACC.org, which is the primary website for ACC, and the chair of ACC's Solution Set Oversight Committee, overseeing policy and clinical documents issued by the ACC. He is a past governor for the Oregon chapter of the ACC and a current board member of the American Society for Preventative Cardiology. He's a liaison for the American Heart Association Council on Quality of Care and Outcomes Research and a site member of the AHA's Target Aortic Stenosis Initiative. I am going to go ahead and turn it over to you, Dr. Gluckman.
Kaylee, thank you for the extremely kind introduction and for the opportunity to be a part of this webinar series. I'm excited to kick things off. I want to say a special thank you to all of you that are participating live. And for those that you will be watching offline on this, excited to introduce and really reinforce the importance of recognizing valvular heart disease Importantly, I want to make time for questions, so please type your questions along the way in the chat, and as time allows, we'll do our best to address them. I might give myself a reminder to mention that again midway through. These are disclosures for me. And these are learning objectives. Our goal is to review the most common forms of valvular heart disease and recognize the symptoms and signs of valvular heart disease in a primary care setting. I wish I, in retrospect, had a slide showing Goldilocks and the Three Bears, highlighting that valvular heart disease, a lot of it is about finding the disease and intervening when it's just right, not too soft, not too hard, or the equivalent, not too mild, not too severe. We'll talk about this across different forms of valvular heart disease, those that are most prevalent. And you're also going to be getting a lot more of that in the subsequent webinars that we referenced in July. So let's start and just really center everybody around what we're talking about. These are figures, cartoons of the heart. As most everyone knows, we have four valves: the AV valves, the mitral and tricuspid valve, the semilunar valves, the aortic and pulmonic valves. And in short, problems can arise across all of these different types of valves. You're seen along the left axis on the left and sort of in a transverse section through the heart. I like the one on the right because it really highlights how interconnected, at least spatially, the different valves are, showing the mitral and tricuspid valves and the aortic and pulmonic valves. And really, they sit, at least in a plane wise, right in the same area overall. If you cut the heart in the midsection along that on the left side, you can see how close in proximity all these valves are to one another. So a busy slide, but just to highlight that various forms of valvular heart disease exist. We could be having an hour-long talk on perhaps every one of these types of valvular heart disease. But in short, you can develop stenosis or narrowing or regurgitation or leakiness of each of these valves. I do call out specifically bicuspid aortic valve disease as a small subset of those individuals who have aortic valve pathology, whereby individuals may have stenosis, regurgitation, or neither in association with a bicuspid aortic valve. We're going to walk through each one of these. So again, as you have questions, please feel free to type them in the chat. So the logical question is, which forms of valvular heart disease are most common? And challenging with this is the fact that we have individuals with valvular heart disease. We don't routinely screen in an unselected fashion individuals out there having valvular heart disease. So when we even look in registries of those individuals that are reported, it often is subject to the limitations of, is there a bias in who was enrolled in a registry, and are we getting accurate reflections of how prevalent this is? This was answered perhaps in this preview valve study, the data of which was presented at the TCT meeting relatively recently from this past year, highlighting 3,000 participants. These were individuals between the ages of 65 to 85 years. You can see some of the sociodemographic data there, who were recruited from retail pharmacy databases to undergo an at-home ECG and an echocardiogram. And it gives you I think, one of the most recent periods of time to be able to look at how prevalent this is. And so you can see prevalence of moderate or greater degrees of severity of valvular heart disease on the left and the age distribution on the right. Overall, 8% of those individuals in this cohort had moderate or greater degrees of some form of valvular heart disease. Interestingly, you can see that tricuspid regurgitation was the most prevalent form, just above aortic stenosis, followed by mitral regurgitation and aortic regurgitation. And then taking all forms of moderate or greater degrees of forms of valvular heart disease, you can see that as individuals aged in this 65 to 85 year age group, the prevalence of valvular heart disease of moderate or greater degrees rose as individuals got older, from their 60s to 70s to 80s. So this is actually a figure taken from the most recent valvular heart disease guidelines by the Europeans, the European Society of Cardiology. And it really highlights the process that we walk through as clinicians in thinking about approaching individuals with valvular heart disease. Again, the subsequent webinars are going to highlight how we utilize imaging, particularly echocardiography, to help in the diagnosis, and then getting people referred for further evaluation, including so-called valve heart disease programs, valve clinics, for further evaluation to determine whether intervention is warranted. I'm going to be spending my time focused in on the clinical examination because you can't obviously refer people for further testing or evaluation unless we've flagged individuals that may have symptoms or signs of valvular heart disease. And this really reinforces the importance of auscultation. And although the stethoscope doesn't get the attention that it deserves, it really is a key tool in your armamentarium to be able to flag individuals that may, in particular, who are otherwise asymptomatic, identify individuals that may have valvular heart disease. Usually, mild and moderate forms of valvular heart disease, the individuals are completely asymptomatic. And I would even say that many individuals who have severe or moderate or greater degrees of valvular heart disease may also be asymptomatic. And so the challenge for all of us is, how do we identify these individuals? It is important to realize that symptom onset is usually gradual and may be misattributed to other causes. So not infrequently, you'll get individuals saying, I was slowly but surely, again, this is often insidious, developing some symptoms. And you sometimes really have to push patients on this to discern their new normal is not normal, but it's been so insidious, slow in onset, it didn't really occur to them that something was wrong. And again, auscultation is critical in evaluating these patients. So we're literally, for the remainder of the presentation, going to be diving in valve by valve to give a framework and perspective of this. As you saw earlier in the epidemiologic data that we referenced, aortic valve pathology, and in particular, aortic stenosis, is one of the more common forms of valvular heart disease that's going to be seen in practice. So aortic stenosis, what is it? And as many of you know, it's a progressive disease that results from calcification and or thickening of the aortic valve leaflets. And ultimately, it leads to a fixed obstruction of flow out of the left ventricle that leads to left ventricular pressure overload and ultimately can compromise cardiac output, resulting in decreased exercise capacity, increased risk for heart failure, and increased risk for cardiovascular death. Not dissimilar from some of the other forms of valvular heart disease that we're going to talk about, prevalence is low, less than 1% of severe aortic stenosis in those under the age of 50 years, and rises to 3 to 4% in those greater than or equal to 75 years of age. Now, that's severe forms. Obviously, as you look back, moderate and mild forms of aortic stenosis are that much more prevalent. Very importantly, the death rate exceeds 50% at 2 years in those with severe symptomatic aortic stenosis without appropriate intervention, most commonly valve replacement. I like the pictorial display on the right-hand side. Any of you that have been this time of years out having to water your yard with a garden hose, you can recognize that you can mimic aortic stenosis by turning the nozzle to, as a result, restrict flow out of the hose. It makes it perhaps more challenging to focus the stream on a broader area, but it gets a much more focused stream. As you can mostly feel, there's greater force or pushback against the same amount of water coming out of your faucet, having to go through a smaller and smaller orifice or hole in the garden hose. The concept is identical in aortic stenosis. And we actually take advantage that you'll hear about in the second webinar about looking at the velocity of flow and the pressure differential across that narrowed valve when we grade or assess the severity of aortic stenosis. Again, these individuals face an increased pressure overload that you'll feel in the hose, but in this case, it's transmitted back to the left ventricle. And there's wide variability in how much obstruction is present before symptoms occur, but the overwhelming majority of people with moderate or lesser degrees of aortic stenosis have no symptoms, and even individuals who have severe aortic stenosis can be asymptomatic. I think this is an important realization that on the right-hand side, this is a classic picture, but it highlights that even for individuals that have severe aortic stenosis, they may be asymptomatic for many years and even decades. And at some point when symptoms occur, sort of the bottom drops out. And you will see that average survival in those that have heart failure, syncope, and angina can be as much as only 2, 3, and 5 years. So put a different way, in those individuals that have overt heart failure in the setting of severe aortic stenosis, they have an average survival of only 2 years, whereas their survival, as you can see in the much bigger picture, is near normal for many, many, many years and even decades in an asymptomatic state. Again, once symptoms develop, most classically exertional dyspnea, exertional dizziness, exertional chest discomfort, those are the things that we ask about. And individuals who have even those symptoms at rest face a worse prognosis, given the fact that they probably have greater degrees of obstruction overall. So the physical examination, which again, we're going to be reinforcing physical exam beyond symptoms in all of our forms of valvular heart disease, classically involves a low volume and slow rising carotid pulse because it's harder to get blood out of the fixed narrowed aortic valve. They have a loud, later peaking crescendo decrescendo systolic murmur heard in the right intercostal space, and often a single heart sound. The second heart sound may be barely audible or not audible again. On the right-hand side, this is visually displayed whether we're talking about systole or diastole. Aortic stenosis is a systolic murmur. The more severe the degree of aortic stenosis, the later that valve peaks overall, because it takes longer for blood to eject out of the left ventricle. And I don't think that this is too hard to appreciate. The murmur of aortic stenosis may actually soften as the severity worsens, particularly if you get less and less blood out of the left ventricle, or the left ventricle begins to fail and has decreased left ventricular systolic function, because you may not have enough blood getting out of the ventricle to produce that murmur. And we're going to produce a sound. This is the sound. That was the sound of the murmur of aortic stenosis. Again, it is a crescendo decrescendo murmur illustrated by B in the figure on the right. That crescendo, initially the murmur getting louder and then getting softer as it moves through systole. We'll do this for several other murmurs as we go along. So we're going to switch to aortic regurgitation. And the question is, what is aortic regurgitation? Well, it's a progressive disease that's characterized by inadequate closure or coaptation of the aortic valve leaflets, most often resulting from dilation of the aortic root, a bicuspid aortic valve, or individuals that have calcific aortic valve disease, which we think of in association with aortic stenosis, can result in failure of the leaflets to coapt together appropriately and aortic regurgitation. Not dissimilar from aortic stenosis, its prevalence varies with age, but moderate to severe forms increases in prevalence as individuals get older. The death rate can exceed 15% at 2 years in those with severe disease without valve replacement, with the greatest risk of death occurring in those individuals that develop left ventricular systolic dysfunction. And as part and parcel of the aortic regurgitation that's illustrated on the leftward side, realize the aortic valve is blown up and that inset. But if you look at the aortic valve, blood's going the wrong direction. As blood goes from the left atrium to the left ventricle, it's supposed to go out the aortic valve, but not return back to the left ventricle. When it returns back to the left ventricle, that volume load puts a volume overload state on the left ventricle, because not only do you have the normal blood coming from the left atrium into the left ventricle with each beat, but you also now have blood regurgitating back from the aorta into the left ventricle, producing volume overload. So patients with aortic regurgitation face increased left ventricular volume that leads to increased left ventricular wall stress. Initially, the heart will attempt to compensate with chronic severe aortic regurgitation by hypertrophying the left ventricle to maintain left ventricular stroke volume. However, over time, the left ventricle can dilate and have a reduction in left ventricular systolic function as a result of overwhelming the compensatory mechanisms of left ventricular hypertrophy that occurs with chronic severe aortic regurgitation. Interestingly, in the middle, in the setting of acute severe aortic regurgitation, the left ventricle doesn't have time to both hypertrophy and dilate, but individuals can face a significant volume load in the left ventricle that can result in many of the same symptoms as chronic aortic regurgitation. So again, individuals with chronic severe aortic regurgitation, not unlike aortic stenosis, can be asymptomatic for years and even decades, despite even progressive left ventricular enlargement and even compromise of left ventricular systolic function. When present, symptoms usually include exertional dyspnea, particularly in those with left ventricular systolic dysfunction, exertional angina, and this may seem at odds with what you might think, but from decreased coronary diastolic perfusion pressure and increased awareness of one's heartbeat, they can feel the increased left ventricular stroke volume. And importantly, on the right-hand side, you can see from a publication that goes back almost 25 years, survival with conservative treatment. So not intervening, not replacing their valve. You can see here the survival curves look worse and worse as someone's New York Heart Association classification or functional status worsens. Their survival goes precipitously down, particularly as you move to those people who have class 3 or class 4 functional status. In aortic regurgitation, physical exam findings include with severe aortic regurgitation, and this is with chronic aortic regurgitation, wide-ranging abnormalities resulting from a wide pulse pressure. The difference between their systolic and diastolic blood pressure widens. That's their pulse pressure. And they can have a variety of findings that many of us probably learned during training, a water hammer pulse, Demusset sign, Traub sign, Quincke pulses. These all result from that wide pulse pressure. And then a high-pitched blowing diastolic murmur that usually extends throughout diastole. There's also a second low-pitched mid to late diastolic rumble that can be heard at the left ventricular apex, referred to as the Austin Flint murmur. And again, on the right-hand side, you can see that the murmur of aortic regurgitation occurs during diastole and occurs largely throughout diastole. And this is what the murmur sounds like with aortic regurgitation. In contrast to the murmur of aortic stenosis that occurs during systole, which has a softening that with the murmur that will get larger and then get smaller, that sort of crescendo decrescendo, the murmur sounds the same and occurs during diastole with aortic regurgitation. So just very briefly with bicuspid aortic valves, this represents a subset of potential etiologies for aortic stenosis, aortic regurgitation, or these individuals may in fact have no aortic stenosis and no aortic regurgitation. It is one of the most common forms of congenital heart disease. It affects 1% of the population. So all of you listening will definitely be seeing people who have bicuspid aortic valves. There is a 2-to-1 to 3-to-1 male to female predominance. It has a genetic predisposition with roughly about 10% of first-degree relatives affected. And the other finding of a bicuspid valve beyond the inset on the leftward side that shows that there are 2 leaflets instead of 3 that may result from fusion of 2 of the leaflets to one another. There's also an aortopathy that occurs with the valve disease, a so-called valvulo-aortopathy. It can include a thoracic aortic aneurysm and other abnormalities, including aortic coarctation, subvalvular and supravalvular aortic stenosis, aortic regurgitation, ventricular septal defects, a PDA or a patent ductus arteriosus, and a sinus of Valsalva aneurysm. I promise this is the only imaging because we're going to be talking about imaging a lot in webinar number 2, but it involves cusp fusion, most often involving 2 asymmetric aortic cusps. Instead of looking like the peace sign with 3 equally distributed aortic valve leaflets, which happen in individuals normally, this individual, as you can see on the leftward upper picture, has what looks like 2 leaflets. You're seeing a 3-dimensional image in the right upper corner here. They have an abnormal valve leaflet mobility, as is reflected in a still frame in the left lower corner. And as is reflected here, this person has an ascending aortic aneurysm, a very dilated aorta that extends, in this case, beyond the level of the valve, but individuals can also have a dilated aortic root. The so-called tubular ascending aorta occurs in about 2/3 of individuals, with a sinus of Valsalva aneurysm occurring in about 1/4. We don't really as well understand why some people develop stenosis, other people develop leakiness of their aortic valve, and some individuals have none of the above. and why some people have aortopathy and others do not. So we're going to move on to the mitral valve. The mitral valve, if specifically mitral regurgitation, is one of the more common forms of valvular heart disease. Looked on the left is looking along the short axis, or if you were to cut the heart transversely, looking at the anterior leaflet and the posterior leaflet that's seen there overall. And then the usual view that we're used to seeing on the right-hand side, a more front axis view, you could see the mitral valve, the associated chordae tendineae that insert and connect into the papillary muscles in the left ventricle. A much more complex architecture of the mitral valve relative to the aortic valve, and thus it makes repair and replacement, particularly that occur in the cath lab, more challenging. Mitral stenosis is just as it sounds, narrowing of the mitral valve. It's a disease characterized by calcification, fibrosis, thickening of the mitral valve leaflets with obstruction of flow from the left atrium to left ventricle. That leads to increased pressure within the left atrium that can get transmitted back to the pulmonary vasculature. By far and away, rheumatic heart disease, having rheumatic fever, developing rheumatic heart disease is the most common cause. We see it uncommonly in the US, more often occurs outside the US, but for individuals that may have immigrated to the US, they may have had rheumatic fever and rheumatic heart disease, or excuse me, rheumatic fever in childhood and developed rheumatic heart disease later in life. Other causes include mitral annular calcification, congenital mitral stenosis, and the risks borne by people with mitral stenosis include more stagnant flow or incomplete emptying of the left atrium that can result in clots forming that can embolize, thromboembolism, increased risk for developing atrial fibrillation, that pressure being transmitted to the pulmonary vasculature and developing pulmonary hypertension, right-sided heart failure, and death. So patients with mitral stenosis can have a long period of time between being diagnosed with rheumatic fever and the onset of mitral stenosis, 16 or more years. Valve narrowing generally progresses very slowly, about 0.1 centimeters squared per year. But once people are symptomatic, progression from mild symptoms to severe disability can occur within 7 to 9 years. And on the right-hand side, you can see the rheumatic mitral calcification reflected by that yellow color that's involving the actual mitral valve leaflets versus on the left-hand side, mitral annular calcification, where there's calcification of the annulus around the mitral valve that at the end of the day can produce a similar picture of compromised mobility of the mitral valve leaflets or stenosis that limits blood emptying from the left atrium to the left ventricle. Individuals with chronic severe mitral stenosis, again, as was stated, can be asymptomatic for decades despite left atrial enlargement, increased pressure. When present, symptoms can include exertional dyspnea, decreased exercise tolerance, and mortality is a function of functional capacity decreases. I will just show on the right-hand side, this is the expected survival of somebody that doesn't have mitral stenosis that you would expect over time. And in those with less than severe in red and severe mitral stenosis, the significant influence of mitral stenosis compared to age-matched controls in accentuating an increased risk for death. Mitral stenosis physical exam findings include a soft first heart sound, a loud P2 component of the second heart sound, an opening snap during early diastole that occurs earlier after the second heart sound as the severity of mitral stenosis increases, and a low-pitched diastolic, so this is a diastolic murmur, that's a rumble best heard at the left ventricular apex. And so we'll play the sound of the murmur of mitral stenosis, severe mitral stenosis. I'm now going to move over to mitral regurgitation that is far more common relative to mitral stenosis. And in the left upper corner, you'll see a normal appearance of the left atrium, the mitral valve leaflets, the papillary muscles, the chordae tendineae. But then you can begin to get into what are the underlying pathophysiologies responsible for this. As is reflected on the right, it's a progressive disease characterized by abnormalities that may involve the mitral valve itself, the leaflets, the chordae tendineae, the papillary muscles, or the annulus, so-called primary mitral regurgitation, or somebody can have an altogether different process, such as prior myocardial infarction, heart failure, where the left ventricle dilates, and as a result of the left ventricle dilating, it pulls apart the mitral valve leaflets, or the subvalvular apparatus, resulting in distortion in how the mitral valve leaflets may coapt normally, resulting in mitral regurgitation. I'll call out that mitral valve prolapse doesn't mean that you will develop mitral regurgitation and progressive disease, but it represents in what's shown in the third of the panels on the left-hand side as just one example of mitral valve pathology that can be associated with mitral regurgitation. So its prevalence varies with age, not dissimilar from everything else we've talked about. Moderate to severe disease, you can see the frequency with which that occurs increases in prevalence as individuals get older. And because blood is normally supposed to travel from the left atrium to the left ventricle out the aorta, when someone has mitral regurgitation, they have an increase in blood regurgitating back into the left atrium. The blood that regurgitated from the left ventricle and the left atrium mixes with the blood that came out of the pulmonary veins that would have normally come anyway. As a result, more blood is transmitted to the left ventricle beat by beat. The blood that regurgitated plus the normal blood that came in the left atrium that goes in the left ventricle, resulting in left ventricular volume overload. And that increases the risk of left ventricular systolic dysfunction. The increased regurgitant blood in the left atrium can cause increase in left atrial size and predisposition to atrial fibrillation. And that increased blood can get transmitted back to the pulmonary vasculature, leading to pulmonary hypertension. Without intervention, individuals with severe mitral regurgitation face a significantly increased risk of cardiovascular mortality. So risk factors for worse prognosis with mitral regurgitation include the presence of atrial fibrillation, hypertension, ischemic heart disease, and left ventricular enlargement. And on the right-hand side, you can see a pictorial display of a normal heart with very modest amounts, we'll call it mild amounts, of mitral regurgitation reflected by that really rainbow-colored jet that's moving the wrong direction from the left ventricle back in the left atrium. Over time, dependent upon some of the risk factors on the left and the underlying pathophysiology causing the mitral regurgitation gets worse and worse, and then it can lead to progressive left ventricular enlargement that actually can make the mitral regurgitation worse. It also can cause progressive left ventricular enlargement and cardiac failure. And again, you'll see at the top, it's this sweet spot about when do we intervene? Not too early when the mitral regurgitation is less pronounced, not too early when the aortic stenosis is less pronounced, not too early when the aortic regurgitation is less pronounced. But if you do it too late, you may have missed your window of being able to effectively intervene and change the natural history of the disease. So ideally, we're pumping the brake and not pulling the trigger to intervene too early, but we want to find exactly when is the sweet spot where we can intervene to prevent progression of the disease over time. Most individuals remain asymptomatic until there's left ventricular enlargement, systolic dysfunction, atrial fibrillation, and/or pulmonary hypertension. The symptoms that most commonly occur include exertional dyspnea and fatigue. And patients with severe MR and left ventricular enlargement usually progress to symptomatic heart failure and pulmonary edema if they don't have an intervention. And this is just illustrated on the right here. Survival is amongst many different things that can be looked at. In this case, is reflective of the left ventricular ejection fraction. In those with a normal left ventricular ejection fraction, or I should say greater than or equal to 60% in the blue line, as their left ventricular ejection fraction falls, so who does their survival or their chance of survival. The other thing to realize is that when we measure left ventricular ejection fraction, we're measuring the amount of blood ejected by the left ventricle per beat. And so a left ventricular ejection fraction of 60% in somebody with severe mitral regurgitation probably already reflects some left ventricular systolic dysfunction, because remember, blood can go both ways. It can go out the aortic valve, or it can go back in the left atrium. So in essence, people with severe mitral regurgitation should have a supranormal, a supraphysiologic ejection fraction, because blood's going two different directions. And thus, even people with what we would consider quote unquote normal left ventricular ejection fractions of 60% in green are getting lower than they should be for somebody who has severe mitral regurgitation. Physical exam with severe MR includes a diminished S1, first heart sound, a wide split second heart sound. They can have an S3 gallop with elevated left-sided filling pressures and a holosystolic, it's a systolic murmur, that's blowing in nature, best heard over the LV apex that classically radiates to the left axilla. And I'll play that murmur. Again, aortic stenosis, mitral regurgitation, systolic murmurs. Aortic regurgitation, mitral stenosis, diastolic murmurs. So this is going to be a systolic murmur, a holosystolic murmur. Great. So let's move on to the tricuspid valve. Maybe a surprise to many of you, tricuspid regurgitation, moderate or greater degrees, was the most prevalent form of valvular heart disease. We see a lot of tricuspid regurgitation. There have been a lot of advances in the field of addressing tricuspid regurgitation. More to come in webinar 3 as it relates to that. Tricuspid valve is one of the AV valves that divides the right atrium from the right ventricle. It has characteristics of chordae tendineae and papillary muscles that it allows it to be connected down into the right ventricle, and a more complex anatomy not dissimilar from the mitral valve. Mitral valve has 2 leaflets. Tricuspid valve is an AV valve, has 3 leaflets, an anterior leaflet, posterior leaflet, and a septal leaflet. So what is tricuspid stenosis? It's an uncommon valvular lesion that's most often due to rheumatic heart disease, not dissimilar from mitral stenosis. It accounts for less than 1% of all forms of valvular heart disease and only 2.4% of cases of tricuspid valve disease. So when you say someone's got tricuspid valve pathology, the overwhelming majority of those people have tricuspid regurgitation, not stenosis. It is often accompanied by tricuspid regurgitation, and its prognosis is most often defined by right ventricular function. Worse function, worse prognosis. Symptoms include fatigue, which usually arises from obstruction of flow and reduced cardiac output out of the right ventricle, but they may also have abdominal discomfort resulting from the transmission of those increased pressures into the right atrium and upstream from that, leading to elevated systemic venous congestion, hepatic congestion, and hepatic or hepatosplenic megaly. Survival probability, as you can see here, is a reflection of the extent of tricuspid valve involvement in people that, in this case, blue, have tricuspid stenosis versus those that don't. You can see over time their survival curves look much worse if they have tricuspid stenosis. Physical exam findings, I don't have an audio for this, but with severe tricuspid stenosis include a soft opening snap, a mid-diastolic murmur. Again, this is a diastolic murmur that's heard best along the left lower sternal border, a place that we may listen to the tricuspid valve, jugular venous distension, hepatomegaly, ascites, and peripheral edema, all resulting from those elevated pressures backing up into the right atrium being transmitted to the venous circuit on the right side of the heart. Let's pivot over to tricuspid regurgitation, which in our initial slide highlighted that moderate or greater degrees, this is the most prevalent in at least that one real-world analysis form of valvular heart disease. The tricuspid valve, again, in this case, as opposed to being narrowed, results in leakiness of blood regurgitating from the right ventricle back up into the right atrium that leads to a volume overload on the right atrium. Its prevalence varies with age, not dissimilar from everything else that we shared. Prevalence increases of moderate or greater degrees of tricuspid regurgitation is as individuals get older, and then greater TR is associated with an increased risk of incident heart failure and all-cause mortality. So with tricuspid regurgitation, not dissimilar from what we talked about with the other AV valve, the mitral valve and mitral regurgitation can have a primary or secondary cause. So primary causes include infective endocarditis, Epstein anomaly, a form of congenital heart disease, rheumatic valve disease, and they're far less common, as we stated earlier, than individuals who have secondary causes. And the secondary causes often can result either from pulmonary hypertension, a process that leads to For example, somebody who had chronic thromboembolic disease or a pulmonary embolism, elevated pressures within the pulmonary vasculature, getting transmitted back to the right ventricle. The right ventricle dilates and it pulls apart the tricuspid valve leaflets, leading to a functional or secondary tricuspid regurgitation. It also can occur in the setting of an RV pacing lead. So if you have a pacemaker that has a lead that goes down into the right ventricle, it passes through the tricuspid valve. And the lead can adhere to the tricuspid valve leaflets, distorting its normal function, or it's just a space where the tricuspid valve cannot close on to the valve as well and can result in regurgitation. Atrial fibrillation itself can lead to abnormal remodeling of the atria that can predispose to tricuspid regurgitation. Patients with severe tricuspid regurgitation may remain asymptomatic for many years. And in fact, some of the best evidence for this is if you look at some of the populations with heightened risk of endocarditis, for example, related to intravenous drug use or abuse, in individuals in whom they are potentially at risk of infecting a prosthetic valve. Historically, some of those patients may have actually had extirpation, where you actually remove the tricuspid valve and there's no valve there. And those individuals have essentially wide open tricuspid regurgitation and may remain asymptomatic for years. The challenge is the consequences long term of that is it leads to a lot of problems. And those problems, as listed in the second bullet point, when symptoms do occur, they can include pulsations in the neck, and that's actually resulting from jugular venous distension, painful hepatosplenomegaly, ascites, and findings from right-sided heart failure, peripheral edema, just to name a few. Tricuspid regurgitation prognosis in part depends upon severity, but to some degree also depends upon the underlying etiology. So this is a cartoon highlighting a normal tricuspid valve to the far left and tricuspid regurgitation that can result from a primary cause, trying to illustrate maybe one leaflet being disproportionately affected of the three. A secondary cause where, for example, the right ventricle enlarges, it dilates, it results in the tricuspid valve leaflets not being able to coapt as well. And then you can see down at the bottom a lead represented by that white dot in the middle that's preventing a leaflet from coming together as well with the others. And you can see the survival probability of individuals that have severe tricuspid regurgitation based upon the etiology, where patients with secondary and lead-associated tricuspid regurgitation fare worse overall. You can also see the size of the pie in the circles at the bottom and along this sort of temperature bar in the middle. Secondary tricuspid regurgitation is the most common, followed by lead-related, followed by primary etiologies overall. Physical exam findings with severe TR, and I don't have a recording of this, I apologize, but include a holosystolic, not unlike mitral regurgitation. This is a holosystolic murmur, but instead of being heard towards the apex rating to the axilla, you hear over the right or left midsternal border. And then if you do a maneuver such as leg raise that will increase venous return, you have more flow going along the right ventricle. That means more flow that can regurgitate from the right ventricle up into the right atrium with tricuspid regurgitation. And you can see a more pronounced murmur with that. Other findings include those related to right-sided heart failure, including distended and prominent jugular veins, hepatosplenomegaly, ascites, and peripheral edema. What about the pulmonic valve? I'm going to highlight the pulmonic valve here is at the top. And this is highlighting the interconnectedness in the horizontal axis. If you were to cut the heart along its mid portion, you can see how closely and anatomically tied in the pulmonic valve is to just below it. You can see the aortic valve, and then respectively, the tricuspid and mitral valves that are illustrated in the bottom portion of this figure. Pulmonic valve is another one of the so-called semilunar valves, which includes the aortic and the pulmonic valves. Pulmonic stenosis is a disease characterized by fibrous thickening and fusion of the pulmonic valve leaflets that leads to obstruction of flow out of the pulmonic valve. That leads to a backward pressure on the right ventricle overall. You also can have right ventricular outflow obstruction below the valve, so-called subvalvular pulmonic stenosis, and above the valve, so-called supravalvular pulmonic stenosis. These tend to occur more often in association with different forms of congenital heart disease. As is listed here, pulmonic stenosis accounts for about 7 to 12% of congenital heart disease cases. And pulmonic stenosis is associated with an increased risk because the valve is not normal of infective endocarditis and arrhythmia. Symptoms of pulmonic stenosis can include shortness of breath, chest pain, fatigue, and lightheadedness. The physical exam with pulmonic stenosis include a systolic crescendo-decrescendo murmur, not different from aortic stenosis, but at the left upper sternal border that peaks later in systole as severity increases, not dissimilar from aortic stenosis, splitting of the second heart sound, and they can have a pulmonary ejection click. Because this is happening on the right side of the heart, you could have prominent jugular venous waves, including an A wave, varying degrees of tricuspid regurgitation. That backward pressure transmitted to the right ventricle can cause right ventricular dysfunction, potentially right ventricular enlargement, dilation of the right ventricle, leading to poor coaptation of the tricuspid valve leaflets and tricuspid regurgitation, and varying degrees of cyanosis if someone has a right to left shunt that's present, an ASD as an example. I do have a murmur that reflects the sound of pulmonic stenosis. I would submit for those of you listening, this sounds a lot like aortic stenosis. It's just where in the body you're listening to that murmur. And then pulmonic regurgitation. PR is a disease characterized by right ventricular volume overload. You're getting more blood moving from the pulmonary artery back into the right ventricle, and that can lead to volume overload of the right ventricle, right ventricular enlargement, dysfunction, functional tricuspid regurgitation. Again, blood going right atrium, right ventricle, out the pulmonic valve, leakiness moving back from the pulmonary arteries back into the right ventricle leads to a volume overload state on the right ventricle. It can occur in young individuals that have undergone surgical repair of congenital pulmonic stenosis or right ventricular outflow tract obstruction, and adults who have pulmonary arterial hypertension or some other form of pulmonary hypertension that leads to enlargement of the pulmonary arteries, perhaps poor coaptation of the pulmonic valve leaflets themselves, and the transmission of that pressure back that can cause more regurgitation. As there's right ventricular enlargement and dysfunction, there's an increased risk of atrial and ventricular arrhythmias, decreased cardiac output, in this case on the right ventricle, but if you don't have blood flowing to the left ventricle, it can also compromise cardiac output on the left side as well and heighten risk of mortality. Patients are generally asymptomatic with even severe pulmonic regurgitation until they develop right ventricular dysfunction. Physical exam findings with severe pulmonic regurgitation include a diastolic murmur. Again, think of this analogous to aortic regurgitation, but on the other semilunar valve, the pulmonic valve. Diastolic murmur, best heard over the left, second, and third interspaces that increases with inspiration. Other findings include a normal jugular venous pressure, a third heart sound, a prominent jugular venous A wave if pulmonary hypertension is present, and a prominent V wave in the setting of severe tricuspid regurgitation. So we're getting to the very end of this, and we'll save time for some Q&A, but I do want to say, hopefully this has set the stage for understanding the variety of different forms of valve pathology that can occur. The challenging thing for all of you, the challenging thing for me is, how do we flag people who most often with mild, moderate, and even severe forms of valvular heart disease may have no symptoms? How do we flag that? And I come back to the stethoscope that I showed a picture of earlier, is your best friend for saying something doesn't seem right. Almost ubiquitously, diastolic murmurs by definition are pathologic. Not all systolic murmurs are, but if there's any question about what's going on in terms of potential valve pathology, further testing, this will be the subject of webinar 2, most commonly with an echocardiogram, can be extraordinarily helpful in teasing out what may be going on, defining the severity of it, and then setting on a path to how do these patients get followed, what kind of surveillance is required. The American Heart Association and this initiative have put together a wide array of different resources for all of you, including materials that are not just directed at the clinical team, but also at patients. And these have been translated, including the more common forms of valvular heart disease, aortic stenosis, mitral regurgitation, tricuspid regurgitation, in English, Spanish, French, and Chinese. There's also a symptom tracker that is in all the languages that patients can use to track how they're doing symptom-wise. And then coming soon are a lot of other resources, including an auscultation guide, an echocardiogram ordering guide. For what we get into in webinar 3, if people are being considered for transcatheter in the cath lab, not the operating room, interventions for their valve pathology, what are the checklists that should be considered in advance, information about a mitral valve prolapse fact sheet, and then a comprehensive clinician toolkit that's available as well. So just in summary, while valvular heart disease is a progressive condition, patients with mild and moderate forms are usually asymptomatic. And to add to the complexity of this, many times patients with severe forms of these disease can be asymptomatic as well. Because these symptoms are often brought out or elicited by activity in individuals who are less active, and that may be for orthopedic or mobility reasons, or they're just not somebody who's particularly active, it can even be hard to bring out symptoms in somebody who we label as asymptomatic, but if given the opportunity to do more, those symptoms would be brought out. Symptoms associated with the most severe forms of valvular heart disease include shortness of breath, chest pain, fatigue, palpitations, lightheadedness. They usually have gradual onset and they may be misattributed to lots of other causes. And the challenge for me and the challenge for all of you is someone has fatigue. Is this due to the heart? Is it specifically due to valvular heart disease? Is it due to something altogether different? And someone has shortness of breath. Is it due to the heart? Is it, if not, what else is it due to? If it is due to the heart, there are many things, ischemic heart disease, arrhythmia, heart failure, valvular heart disease can all cause shortness of breath. So what may be the cause for that? And I would leave you with the fact that auscultation with the stethoscope is critical to help with detection, diagnosis, and monitoring of valvular heart disease. It's not your only tool in the toolbox, but I would argue it's one of the most important in flagging people that may have valvular heart disease. And with that, I'm going to open things back to Kaylee. I think we've got about 6-7 minutes to be able to go through for questions that may have come up in the chat or others that may have been put forward.
Thank you so much, Dr. Gluckman, for an amazing presentation. I think that was a great way to set the stage and really give a nice foundation for this group of people that are able to attend our series. Let me just open up our Q&A here. I know that we do have a few. All right. Why does tricuspid regurgitation cause painful HSM and not painless hepatosplenomegaly?
And to be clear, it's a phenomenal question, but it's not a given that somebody has to have symptoms or abdominal pain from hepatosplenomegaly. As you probably know, many of our patients may have enlargement of their liver and or spleen with no symptoms whatsoever. So I didn't mean to imply they absolutely will have symptoms. But in a world where a lot of patients who have severe disease may be asymptomatic, they may say, I'm having some abdominal discomfort. And in fact, we've seen people who have right upper quadrant discomfort, not necessarily to palpation, but what they can feel. And it turns out that their hepatosplenomegaly is causing symptoms, but it's due to an upstream problem, namely the heart.
Great, thank you. How can primary care physicians and providers distinguish between heart failure symptoms due to valve disease versus other causes?
It's a phenomenal question, and it can be really challenging. I will tell you that in the case of heart failure, individuals can have other physical exam findings that may be indicative of heart failure. Often, but not always, people may have biventricular, so volume overload manifestations involving both the left and right sides of the heart. Complicating this further is a chicken versus egg scenario. If somebody has heart failure, did the heart failure lead to enlargement of the left or right ventricles or both that then led to valvular heart disease? So, which came first is a really hard thing to sort out. I think the most helpful thing is that if people have symptoms that are unexplained, asking the question first, could shortness of breath, probably the most common symptom that somebody with heart failure and or valvular heart disease has when they have symptoms, um, get further testing, sort things out. And again, webinar number 2 will be about what that testing could be with a focus on valvular heart disease. But very quickly, you'll be able to get an assessment of, are the chambers enlarged? Is the left ventricle, the right ventricle dilated? What's the left ventricular systolic function? What kind of valvular pathology, if any, is present? And I'll take you down that path. But it's a great question, and it's very challenging.
I think we have time for one more here. When patients report fatigue or dyspnea, what clues could suggest a valvular origin?
And this is really challenging. I would say you all probably have individuals that will come in if they don't actually say it on their own. If you push them on it and said, "Do you ever have fatigue?" The answer probably is yes. Who doesn't have fatigue? I think even more challenging with a lot of these forms of valvular heart disease is it's very insidious. So if you really push people on it, for example, with aortic stenosis, they may not even say they're short of breath, but they're like, I used to walk 3 miles. I'm now walking 2. I don't notice any symptoms, but they've slowed down. They're now walking 1 mile. No symptoms. But if you were to push them on it, they're no longer able to do what they were able to do. And often, subconsciously, they're limiting their activity so as to not bring out symptoms. That could be shortness of breath or it could be fatigue. And often people have a hard time characterizing, am I really short of breath? Or is it just I don't have the energy level, the stamina? A lot of words could be inserted in here. I feel fatigued. I don't have the energy level to do what I wanted to do in the past. I don't have the oomph or the capacity to do it. And then the question is the valve playing any role? And I come back to the stethoscope because in somebody who has a murmur and has fatigue, the question is, are those true, true, and related or true, true, and unrelated? And that's something where further testing can be sorted out. So again, it's my call out, a good thing to end on to say, your stethoscope is probably one of your most helpful tools in the toolbox, at least to start directing you down a path. It may end up that both groups of patients with fatigue end up with an echocardiogram, an ultrasound of their heart, but the stethoscope, by listening and auscultating, can help clue you in at least a little bit on advance. Am I more worried about a valvular heart disease cause? Which valve do I think is going on? If this is in systole, do I think differently about which valve pathology from diastole? And feel free offline as this becomes available to go back and listen to those murmurs, because I think it will be helpful just as a pattern recognition of what you'd expect for different types of valve pathology.
You, Dr. Gluckman. And thank you to all of our attendees for being a part of this today. Really appreciate Dr. Gluckman taking the time out of his busy schedule to be able to share with us all of his knowledge and expertise. You will be receiving an email with a link to claim your continuing education credit. And if you should have any difficulties, we do have an AHA contact on there as well. So feel free to email Kristen. And this is going to end our first webinar. So thank you so much. If you've not registered for the next 2 webinars, we do have one July 7th and July 29th. Check out our website and we will make the slides available for you afterwards. So please feel free to reach out if you have any questions. And thank you again.
Kaylee, thanks a lot, and thanks to the HA and the CDC for all the support for this. So thank you all for participating today, and thanks for having me.
Absolutely.